I'd like to discuss some approaches to studying racial disparities in health services research. And this has been a topic that's been especially relevant to some recent work that we've been doing, and I'm going to use our recent work as an example. So first, I want to acknowledge that I'm absolutely not an expert in this topic, clearly, and I'm trying to learn and do better. So Jane Delgado described how cultural beliefs and values become lenses through which researchers and clinicians experience the world, and they often harden into biases that act as intellectual blinders. So to this end, social scientists, including Fjord and Arhi Buya, have used the critical race theory framework to outline these positive obligations of health researchers, which include taking a really critical look at how we, a deep look at how we conceptualize and measure the world and construct knowledge. So this is a really heavy, conceptually heavy diagram, and I think probably poor form to start so early in the talk, but the point is it's really functioned for me to illustrate just how fundamental a change is needed to really meaningfully address health equities. As we're all aware, understanding how racism shapes inequities in healthcare and outcomes has been a topic that's been building over decades, and there's been increased political and social traction over the last few years. Of course, in nephrology, a lot of the conversation has been around understanding race in research. And a lot of this conversation has been focused on understanding the race coefficient in EGFR equation, and that's meant really understanding and reconceptualizing the original studies that led to the EGFR equation. There's been a lot of really great nuanced conversation about whether race is meaningful in this context, and Dr. Guman and Hufnagel, of course, discussed last week that we're moving toward just excluding the race coefficient from this equation. But in health services research, of course, we can't just simply exclude considerations of race. Racial inequities are one of the major patterns that we're trying to study and address. So there's a question of how we understand meaning and appropriate use of race in health services research. This article in Stat News is definitely worth reading. Obviously not an easy read for a white researcher, but important. It highlights how, among other things, even well-intentioned health equity research can be unhelpful and even harmful if approached without relevant skills and perspective. This idea of race as a social construct is in common parlance. That is the definition of race, not as a biologic or human category, but as a social construct, a categorization of people that we've variably defined and made meaningful. But it's a complicated concept, and it's not universally internalized at this point. This article points to a few examples of research published during the pandemic in prominent journals that still suggests that racial disparities in COVID health outcomes might be attributed to genetic or biologic factors. So we still have a ways to go as a scientific community. So here's a quick plan for the talk. I'm going to describe this recent project that we've been working on. I'll touch on some of the questions that have come up for this kind of work and how we use the race variable, how we define racial exposure groups, and then I will refer to some opportunities to improve on our approach in health disparities research. This talk is clearly framed around conducting research, but of course, I'm intending for it to be relevant to clinicians and leaders too. I think there's really an onus on any consumer of research to take a critical look at and understand the assumptions that go into that kind of work before applying it to patient care or policy development or other implications. So first, I'll summarize our recent project. So we know that in the US, kidney disease disproportionately impacts Black, Indigenous, Hispanic, and Asian populations. And of course, there's also huge disparities in access to care, health outcomes, and end-of-life patterns. We also know from research and from many clinicians from personal experience with patients that advanced kidney disease and treatments like dialysis and transplant involve emotional, existential, and spiritual challenges. Davison and colleagues have identified these major unmet needs among people on dialysis and coping with and adapting to illness and navigating psychosocial stressors. But I'd say that we still know very little about whether there are racial differences in these kind of important supportive and existential care needs. So to address this question, we used data from the U-State survey, and that's a study conducted by Drs. O'Hare, Hall, and other colleagues among about 1,000 adults receiving dialysis in Nashville and Seattle. And among other background questions, patients were asked to self-identify their race. And they were also asked about a series of supportive and existential care needs, just giving a few examples here. So for instance, they were asked to answer yes or no to, I would like help with worries I have about the effect of illness on my family, help with finding meaning in my life now. So we were interested in the association between this first question and each of the second questions. So between self-identified race and these kinds of care needs. And we adjusted for demographic characteristics, health status, educational attainment, and spirituality. So as had been described by Davison, as I mentioned, all racial groups expressed substantial unmet supportive and existential care needs. But even after adjusting for differences in measured characteristics, Black participants were more likely to report a range of needs compared with white participants. So for example, they were more likely to say they needed help with finding spiritual resources. They wanted to learn more about what to do about pain. They wanted to talk about finding peace of mind. Asian American or other Pacific Islander participants were also more likely to report a range of unmet needs compared with white participants. They wanted help with coping with sadness, finding hope. They wanted to learn about treating symptoms of kidney disease. They wanted to talk about finding peace of mind. In fact, there were 8 of these questions about supportive and existential care needs, and there were none for which white participants were more likely to express unmet needs. So I'd say this is concerning. These kinds of fundamental care needs have been shown to be central to patient care experience and outcomes. And our results here are suggesting that patients, Black populations or Asian American populations, are less likely to be receiving the kind of care that they need and want. The problem is that this kind of analysis leaves us a bit short on what's happening, what's causing this to happen, and how we can address it. So let's take a step back and think about what this analysis is really telling us, to think a little more deeply about that question. So a lot of health disparities research is framed around this simple causal model. The goal is to describe associations between race and outcome. But there are some serious limitations to this kind of simple conceptualization. First, race as an exposure is not modifiable. It's not something that we're looking to change in itself. And that makes it difficult to identify opportunities to intervene on these concerning patterns and improve care. And second, it's been suggested that merely framing this association in these kinds of simple terms, that race causes these outcomes, without a mechanistic explanation of why that's happening, might reinforce these implicit assumptions that race has some biologic significance. That is, that there's some intrinsic factor about race that causes poor outcomes. So the social scientist Ellie Lett and others have suggested that as health equity researchers, the exposure that we're really interested in is not so much race as systemic racism. So race is the variable that we have. It's an available surrogate marker for what we're actually interested in. I found this psychology experiment by Rebecca Bigler helpful in grasping this conceptual difference here. So a little bit of an aside. Briefly, the experiment was that elementary school kids were randomly assigned to wear either a yellow or a blue t-shirt at school. And for one group of kids, that's all it was. They every day wore either a blue shirt or a yellow shirt. For a second group, in addition to wearing those shirts, they had these posters put up in their classrooms where people with yellow shirts were doing great things. They were smiling and succeeding, things like that. And then there was a third group who wore the shirts, had these posters, and in addition, teachers were instructed to categorize kids by their shirt color. So blue kids sit here, yellow kids sit here, blue kids are doing this project, yellow kids are doing that project, et cetera. And researchers found that only in this last group did kids develop different attitudes about their classmates with different colored shirts. So otherwise stated, it's not the shirt color, of course, that's setting up these different kid attitudes. It's one, the messaging from the teachers that shirt color is a relevant way to categorize each other, and two, messaging from the posters that color signifies some sort of social hierarchy. So by way of analogy, it's of course not the color of people's skin that causes poor outcomes, nor is it some biologic difference signaled by skin color, but it's the underlying cause. What we're interested in is better described by the racial categorization and hierarchical society in which we all live. So this shift of thinking about exposure as racism is helpful because it allows us to better understand multiple types of mechanisms that could be at work. Systemic racism has been defined in multiple different ways. This is one from the AMA. And it's described as a system of structuring opportunity and assigning value based on a phenotype race that unfairly disadvantages some individuals and communities and advantages others. Systemic racism can be mapped also in different ways, but one framework involves distinguishing individual and structural types of racism. So individual racism happens between or within persons and can be internalized. So acceptance by the members of stigmatized races of negative messages about their own abilities and intrinsic worth. Or it can be interpersonal, so expressions of racism between individuals, harassment, racial slurs, racial jokes, things like that. And then structural racism on the other side includes geographic environment, policies, practices that have been put in place over the history of our country and can be described as practices and policies in progressively more local environments like institutions and organizations. And then of course, structural racism, or individual and structural racism can be mutually reinforcing. So systemic racism, then we can talk about that as manifesting in multiple causal pathways in which we can potentially intervene. So for our project, racial groups may have had different supportive and existential care needs stemming from a range of each of these types of racism. So for example, there might be differences in educational and health literacy, access to kinds of care that feels welcoming and emotionally safe. Care processes might have been designed more around the needs of white populations. Relationships with clinicians may have been shaped by implicit biases, all conjectures that we are not really testing in this kind of study. And then just to add another consideration, another important consideration is that while expression of racism might be what we're interested in identifying and changing, differences between racial groups might not all be driven by these forms of racism. That is, not all differences are disparities. In some cases, differences might relate to patient preferences in some contexts. I'd say, just as a caveat, I think it's this idea of different preferences and needs are probably sometimes difficult to disentangle from more distal impacts of racism. So for example, what we're seeing is differences between racial groups in the degree to which supportive care needs are met. But even if those differences are driven by different preferences for these kinds of care, this pattern still suggests that the healthcare system is better designed to accommodate the preferences of white groups for others. And I think that might constitute a disparity in itself. So with that understanding of race as a surrogate marker for racism in mind, we can take another look at this variable for our project. So here are the results of self-reported race for this cohort. Unfortunately, you can see that despite a relatively large cohort in total, there's a small sample size of people reporting race other than white or Black. So our methodologic options, if we want to actually make inferences about patterns beyond just describing patterns for this particular sample, are that we can just focus on Black participants and white participants, exclude others, or we can selectively group certain populations that might have some commonalities in terms of the exposure of interest. And in particular, Asian American and Native Hawaiian and other Pacific Islander groups are sometimes combined to this Asian American Pacific Islander group, AAPI. And the main reason to do that is that AAPI populations are hugely understudied. Just as an example, or to give you some context, this group constitutes a pretty significant part of the US population and is definitely growing, but focused studies make up a tiny percentage of the NIH budget. And then of course, little is known about specific kidney care needs, including supportive or existential care needs. On the other hand, the problem with combining these groups is that there's huge heterogeneity in social and cultural features between these groups. Clustering of racial groups can mask important socioeconomic differences, access to care, health outcomes. So for example, when grouped together, Asian Americans have a higher median household income than white Americans, and much higher than the national average. So you might conclude, just looking at this superficially, that this group is less in need of support. But then if you split up this really heterogeneous group, different subgroups have hugely different income medians, many below white groups and the national average. So this question of whether to group versus split these heterogeneous populations is a methodologic and conceptual problem for all kinds of cohort studies. We have to decide where to make arbitrary cuts in age groups, kidney function, things like that. And we know there's going to be variation within those groups. But there's also ethical concerns about clustering racial categories. First, clustering or collapsing these racial groups feeds this societal misconception that minoritized racial groups are monolithic and homogeneous. And a manifestation of this problem for Asian Americans is the model minority stereotype. And that involves this assumption that all Asian people tend to achieve higher socioeconomic status, educational levels, et cetera. And the concern, of course, is that obscures true healthcare and other needs, and can even reinforce discriminatory behaviors and acts of violence. So there's a lot of discussion about these kinds of considerations, clearly really challenging. And our study group ultimately made the decision to go ahead and group these populations into a combined exposure group, with the hope of really contributing to what's a sparse literature on these populations. But we're fully recognizing the important limitations, and we plan to emphasize that these preliminary signals should really be followed up with more granular studies. So all that and more to consider, I think it's apparent that race is a pretty limited and inadequate surrogate variable in a lot of contexts. So the question is, how do we improve in studying racial disparities in health services? So I'm going to lean on this nice framework by Ellie Lett. And for anyone interested, I'd highly recommend this paper. Very practical commentary on interpreting race in disparities research. So first, we can measure elements of systemic racism in our analyses. Otherwise stated, we can employ more direct, specific measures of types of racism that we think might be in play. And I've included just a few examples of measures that might better identify specific mechanisms of racism here, and grouped them into the categories of systemic racism. I do note that there are many health equity scholars that are cautioning against trying to completely eliminate the race variable, because new measures like these, some of these are pretty well established, but new measures will have to be validated, and it's unlikely that we're going to be able to capture all aspects of experience of different racial groups. I just wanted to highlight a few of these specific examples to give you a more concrete idea. So this is a nice illustrative example from Drs. Rodriguez and O'Hare and their colleagues, looking at how race and neighborhood racial composition relate to kidney transplant among people with end-stage kidney disease. So the y-axis here is the proportion of surviving patients left without a transplant. So higher is worse. And you can see that the proportion is higher for people living in a zip code with greater than 75% Black residents. But within that neighborhood, so these are both lines of people living in that zip code. And this is a line of people, individuals who are Black and individuals who are white. And you see that within that neighborhood, there's not a huge difference. But interestingly, they found different patterns about the relative contribution of neighborhood versus individual race for survival outcomes, other outcomes. So to make the point, had they done this analysis just including individual race, the researchers probably would have found what's been described frequently elsewhere, that Black race was associated with a lower likelihood of getting a kidney transplant, but we'd be left without this understanding of any kind of underlying mechanism. So these more specific measures help us parse what some of the structural mechanisms for disparities might be and give us more targeted interventions. Here's another example. The Everyday Discrimination Index is a well-described measure of self-reported experience. It's been around since the 1990s. And just as an example, Cobb and his colleagues used this measure to show that experience of discrimination is associated with lower EGFR. And that's even after adjusting for demographics, including race, for clinical risk factors, for smoking and other socioeconomic factors. I also wanted to highlight that these investigators included this nice diagram of how they were conceptualizing the interaction between their variables. And that gets us to this second opportunity to improve, which is leaning on theoretical frameworks. So you will probably agree that even this model of systemic racism with these three major pathways is going to be insufficient for describing real relationships. Just as an initial example, these types of racism interact and can be mutually reinforcing. Additionally, people within racial groups who are exposed to these kinds of racism may have hugely different experiences depending on their age, their income, gender, other factors. So ultimately, it's difficult to depict these kinds of complex relationships in these linear diagrams, and we need models that better account for this kind of complexity. And with these more complex models, we also need alternative methods to study these phenomena. So methods like network analysis, qualitative studies are specifically designed to handle this kind of complexity in relationships and processes, and maybe more adapted to answering some of these questions. So finally, these multiple critical actions on this last slide deserve their own discussion, but all these points so far have really highlighted that researchers, especially white researchers, can have blind spots and assumptions that can block progress in this area. So there's also need to promote researchers of color and team with members of impacted communities to shape and implement research. So to summarize, first, showing associations between race and outcomes is just not enough in health disparities research. There's been a move to reshape medicine from an anti-racist perspective from the ground up, and disparities research is no exception. That includes really looking closely at our assumptions and making these explicit and conceptual models, and then fitting the research approach to the question and the goal at hand. And then finally, developing relevant questions, designing research, disseminating research all benefit from teaming with community members with different perspectives throughout the process. Thanks to the collaborators on this U-State project, everyone really was very thoughtful about challenging the approach in a constructive way. And special thanks to Drs. O'Hare, Hall, Young, and Rodriguez for reviewing and discussing some of the aspects of this talk. Thank you.
Thank you so much, Kate. Questions for Kate, comments?
I can pop in. I thought that was great. So thanks, Kate, for that very eye-opening overview. The one question that came to mind was, when we think about outcomes, and you kind of touched on this, are our outcome measures actually sort of inherently biased towards what we consider to be, as sort of an institutionally white sort of practice, what a positive outcome. There could be folks out there, for example, Asian Americans who might prefer to adopt a more Asian medicine type of approach, which we might, that might not be translating into the outcome measures that we're looking at, but from their perspective may actually be the right outcomes.
I totally agree. I think the farther you dig into this, the farther you realize how much our system is structured around certain assumptions of the dominant population. I think things like developing patient-reported outcomes from scratch are a start. But I mean, my personal feeling is that things like qualitative studies that really, although, we realize that it's not possible to completely blind ourselves, from our assumptions, try our best to go in without preconceived ideas of what we're going to find. I've found really compelling and enlightening on this point. I agree.
Actually, maybe I can ask a question. Kate, that was amazing. Thank you so much. I think one of the biggest issues that I see, when I come from a transplant perspective is this, and I think we've talked about this, is this limited resources perspective where, like when people are trying to measure outcomes, people are trying to use outcomes as a measure, and then you're trying to say, hey, we need equity, but then at the same time, you're trying to measure some kind of outcome where you're saying, hey, these are the people who do better. These are the people who are going to get this limited resource. I know this is probably a very hypothetical question, but how do you feel we can reconcile this?
Well, Kant said, no, I mean, that's a hugely philosophical question. Let's talk more. This idea of balancing, how we most efficiently utilize resources versus incorporating equity, I think, is hugely complicated. I'd say the advance during the pandemic, especially when we've been really faced with these problems head on, and in transplant as well, of course, where it's explicitly discussed, is that at least we're recognizing that it's a problem. We're recognizing there's this tension as opposed to going based on our defaults, which as clinicians, we know, and studies have shown that we tend to often focus on what's most, utilizing resources to the greatest effect, whereas we might not consider these alternate important values. Yeah, I totally agree.
Thank you so much, Kate. Very thought-provoking